Welcome everyone to our educational webinar on RSV and other respiratory illnesses. It's exciting to see so many people joining us today. My name is Mary Lizakowski, and I'm a Coalition Health Director with the Foundation for a Healthy North Dakota. We are a new nonprofit, and our mission is to promote health and wellness across North Dakota by working at the community level. We are growing a statewide coalition that will enable local communities to collaborate and work together on common initiatives. By becoming a member of the coalition, you'll be the first to receive information on educational opportunities such as this one, updates on relevant public health information, legislative news, as well as access to digital advocacy resources and toolkits. Just some housekeeping things to touch on. Webinar attendees are automatically muted for this presentation. If you do have questions, please put them in the Q&A box, and our team will be monitoring the questions that come in. We are recording the presentation and will reserve time in the end to answer any questions. After the presentation, a link of the recording will be sent out along with an evaluation survey. It's my pleasure to introduce our presenter today and our storyteller. Dr. Hanson is originally from Mayville, North Dakota. She attended Creighton University for medical school and pediatrics residency at the University of Wisconsin. She has been with Sanford for 15 years and is a general pediatrician providing acute and ongoing care for children from birth through 18 years. She treats a variety of childhood illnesses, chronic health conditions, and behavioral health concerns, and provides health education and wellness counseling. She is the Chief of Service of Sanford Children's in the Fargo region, and also serves as the Department Chair for Pediatric Urgent Care and the Child Maltreatment Program. She actively participates in governance through roles on the Credentialing Committee, PEC, and the Council of Governors, and is clinical faculty for the University of North Dakota Medical School. So welcome. And next we have Siri Thaden with us today. She will be sharing with us the emotional journey of her son Ivor's illness with RSV and the difficulties her family encountered during this time. And so I will stop sharing and I will turn it over to Dr. Hanson to begin.
Just going to give me just a second to get my slides up here. All right, so I'm going to spend time today primarily talking about RSV because I think that's particularly top of mind for people this season. We've got some new exciting things on the vaccine forefront, and I think there's been a lot of conversation both amongst healthcare people and lay people about RSV this year. But just want everyone to know that during my Q&A time, if we want to talk about some other respiratory illnesses, particularly vaccine preventable illnesses, I'm okay with that too, because you know, after working in the urgent care recently, I can tell you we still have influenza and COVID and all of those other rhinovirus, enterovirus, and a little bit of a pertussis outbreak going on. So there's definitely some other illnesses that are affecting children and their families. A little bit about me. I don't have any disclosures to report. As Mary said, I'm a practicing general pediatrician. I've been here at Sanford for the past 16 years, and I've cared for many children with RSV over that time, probably numbering in the thousands. Something to note, my only sick day off during my 3-year residency was when I had RSV. I was rotating through the NICU, and the team there didn't want me anywhere near those babies. So I gladly took some R&R at home during that time. So just kind of a brief overview. And even before we talk about RSV specifically, I just wanted to just give a little reminder about viruses and how viruses work. So viruses are infectious particles that cannot exist out of a host cell, or not for very long. They require a host cell to do their replication. So when you are infected by a virus, it's actually entering a cell in your body and then using your own mechanics to reproduce itself. And that's how it survives. So when we talk about viruses, we will talk about what are their host organisms, or how they're spread most commonly. So just a little bit of a tickler there about RSV, but this is an incredibly common respiratory virus. It's seen around the world. Almost all children contract RSV by the age of 24 months, and you can get reinfected with it throughout the entire lifespan. So I think there's kind of this misnomer that RSV is maybe a disease of babies or a disease of toddlers, but as we're going to see in some future slides, it really can affect people in different ways throughout their lifespan. Most people do recover quickly. We see the pictures, we hear the horror stories about hospitalizations and babies having some really serious complications from RSV. But I do want to remind people that most people who get it, it remains an upper respiratory infection and acts a lot like a cold. Infants and older adults, particularly people over the age of 65, do have a higher likelihood of having severe disease, though, and might require hospitalization. That could include mainly lower respiratory tract symptoms, so things that affect the lungs directly. My husband told me to put this slide in, and he wanted to remind everyone it's not funny. Our child had RSV as an infant and was hospitalized as well, and it really had an impact on him, on the family, and I don't want to underestimate what happens. And we'll hear more from Siri as our storyteller about her journey with her son's battle with RSV. So RSV is an enveloped virus. It's of the RNA variety, so that's the type of mechanics it uses for reproduction. And there's really two main strains of RSV, an A strain and a B strain. We don't really care to differentiate between them because they cause very similar symptoms, and it doesn't really matter which one you have. And they're typically circulating at the same time during the same seasons. The envelope, or that outer coating of the virus, has three surface proteins. So it has glycoprotein G that allows it to attach to the cell and helps kind of skirt the immune response of the host. Fusion protein F, which allows that virus after attachment to get inside the cell. And then hydrophobic protein SH, which does the same thing, really helps with the virus entering into the cell. Here's some pictures, both a cartoon representation and then electron microscopy of what the RSV virus looks like. So you can see on the left, it's that multi-layered structure that's just in the process of attaching to the host cell right here. So you can see it's made contact, it's opened up its wall, and is getting its machinery into the cell. And then in the cartoon, you can kind of see the layout of those specific proteins we talked about, the F glycoprotein, the SH protein, and the G glycoprotein. Those are the main players. The reason those are important is because once we understand the proteins that are at play in a virus, we can start to do some more research and development on how to outsmart it. How do we neutralize it? How do we evade it or keep it from attaching or entering the host cell? So that's really where the research focus is when we're talking about vaccine development and some of those characteristics. RSV as a virus was first identified in the 50s. So, I think a lot of people maybe think this is more of a modern thing or more of a new thing. This has been around for decades, and we've long known that this is a big player in respiratory infection throughout the world. Humans are the only source of infection. So this isn't a virus that we're getting from our pets or spreading to our pets. That virus really is specific to the human cell. And it's transmitted either via direct contact or close contact with the contaminated secretion. So we're talking mainly about snot and mucus, and then infectious droplets like saliva. It can spread probably not farther than 6 feet through large droplet spread. So being in the same room, it depends on the proximity to other individuals, but you can also be infected by touching contaminated surfaces and then touching your mouth or your nose. That viable RSV virus can persist on a surface for hours. So just on a tabletop, a doorknob, a faucet handle, you can definitely contract a living virus that way. And then on your hands can persist 30 minutes or more. So again, why we focus a lot on hand hygiene when we're talking about reducing spread. Typically, a person will shed virus for about 3 to 8 days during their illness, but it can be longer in really young children or in kids who are immunosuppressed. So maybe they've had a solid organ transplant or a stem cell transplant, and they're on medications that are suppressing the normal activity of their immune system. They might be spreading virus for a longer period of time. Takes about 5 days after you're exposed to RSV to develop symptoms. That's kind of the standard for a lot of our cough and cold viruses. That's what we see with flu. That's what we see with COVID. So it's typically that last known exposure, up to 5 days, you still are at risk of developing symptoms. And then about 1 to 3% of infants under 12 months of age require hospitalization. So about 1 to 3 out of 100. And we'll talk in a bit here about why are some reasons that younger kids might be hospitalized and what are those more severe symptoms. RSV has a seasonality like many of our coughs and colds. Starts kind of in that mid-September to mid-November range. So that we know the season starts when we start seeing a sustained rise in the number of RSV positive tests. We see the season peak when we see that maximum number, and that's usually sometime late December to mid-February. And then the decline of the season, when you see that sustained drop, is from about April to mid-May. So you might look at that and say, gosh, we're looking at a good 5 or 6 month period out of the year where we may be seeing cases of RSV. That seasonality also varies depending geographically on where you live. So Florida really does not have this type of seasonality pattern. This is much more of a Midwest pattern that we're looking at. And around the world, of course, we see different peaks and different seasonalities to this virus too. One thing that was really unique was the 2022-2023 RSV season. We really saw our seasonality get disrupted, and we think the reason for that was because of the isolation that we did during the COVID pandemic. Kids did not have their typical exposure to coughs and colds. And so then when we started rejoining the world and people were back to school and back to daycare, we really saw RSV occurring out of season. So I don't know if any of you remember that, but we had really a lot of respiratory illness in August and September of that year, just when school was starting. This year, it does seem to be falling more in that typical seasonal pattern. I would say we started seeing locally RSV rates and bronchiolitis rising in December and January, and kind of still in the thick of it right now, though I think we may have hit our peak. You might look at that peak and say to yourself, well, isn't that just like every other cold and flu that we see going around? And the answer is yes. So I think right now we're following into this pattern where we see influenza, RSV, and COVID kind of co-mingling and possibly even co-infecting in the same season. So it's possible to be infected with more than one virus at the same time, and that can impact the way that your immune system handles those infections. It doesn't necessarily put you at higher risk for developing severe disease, although it certainly can. But it may impact the way that you have immunity going forward in the season. So, for example, if you have RSV and influenza at the same time, your immune response to RSV may somewhat neutralize your immune response to influenza, leaving you susceptible, later on or sooner than you normally would after infection. I like this picture of myself because I don't know if you can see it, but I'm wearing two things that talk about vaccination. So I have my sticker saying I just got my flu vaccine, and then I have my badge reel that says I got my COVID vaccine. And I'm also wearing a mask. This is just good reminders about we have strategies to help prevent and or minimize the risk of infectious disease amongst people who work in the healthcare field, amongst our kids, amongst our vulnerable family members. And so there are steps you can take each year to try to minimize that risk to yourself, but nothing is perfect. So it's got to be a multi-layered strategy. This is another slide that's looking at the past 5 years of RSV seasonality. So you can see here, this dark colored line, this solid black line, was the 2022-23 season that I was talking about, where we saw that increase in cases and that spike much higher, sharper, and earlier than we did in other years. In our current year, again, we're following, I think, what's felt to be more typical. We're getting that rise here, hitting our peak here in January, and then hopefully as the weather warms up, we're going to see things start to diminish. Just thinking about the burden of RSV disease in the US, and again, this is just the US, this is not talking about worldwide. Certainly these numbers look different in a developing country than they do here, but in just the US alone, we have over 2 million ambulatory visits every year due to RSV. So that's 2 million patients who are being seen in their pediatrician's office, in their primary care office, in the urgent care, and have RSV. This affects our elder adults. So adults over the age of 65 have somewhere in the neighborhood of 60 to 100,000 hospitalizations due to RSV per year. That number is a little bit lower in kids, not because kids are less severely affected, but just because the total number of kids less than 5 is a smaller number overall than the number of adults over 65. But still seeing a significant number of hospitalizations there each year due to RSV. We see quite a number of deaths in the elder population due to RSV, as well as a handful of deaths in children less than the age of 5. So really seeing some impact to our healthcare facilities and to our patients because of RSV. So let's talk a little bit about the clinical manifestations. So even in infants, typically RSV is still an upper respiratory infection. So might present with a runny, stuffy nose. They may or may not have some fever. They may or may not have some cough along with it. Very difficult in that setting to distinguish it from any other upper respiratory infection, whether it's rhinovirus or adenovirus. They have a lot of similarities and a lot of overlap. What's different about RSV than maybe some of those other infections is that about 20 to 30% of infants will develop what we call lower tract disease. So that's things like pneumonia or what we call bronchiolitis, where their symptoms are more severe. They might have greater difficulties with breathing. They may have greater mucus production. They might have a lot more wheezing or inflammation along with their RSV infection. So that's not an insignificant number of kids who develop bronchiolitis because of their RSV infection. The kids I really worry about in my practice or when I'm working in the urgent care are those neonates who are in the first few weeks of life. So they may present in a much more tricky way. They may have a lot more vague symptoms. They might just seem lethargic. They might present with poor feeding or just plain old fussiness. Those neonates do not have a lot of ways of telling us what their illness is. And so it's really can be tough to sort out, like, well, do you have meningitis? Are you just having a bad day? Do you have, are you coming down with some other cold? Do you have colic? A lot of those things have overlap. And so I would encourage, parents and clinicians, if we're in RSV season and you have a new baby who just seems off, have RSV in your mind. And one of the things that's unique about those neonates as well is that they can present with just isolated apnea. So they're maybe feeling a little bit off and then having times where they're having long pauses in their breathing or even stopping breathing altogether. And so that can be a presenting sign of RSV even without that coexisting, cough, runny nose, or fever that you might see in an older child. Most kids with bronchiolitis, so that lower tract disease, do not require hospitalization. So we see these kids all the time in the urgent care who started out with cold symptoms that then progressed on to wheezing and mucousy airways. And a lot of those kids can power through that and will do okay. But a handful of them do require hospitalization. Typically, those stays are brief, usually in that 2 to 3 day window, although we may see kids who have more severe disease that have a longer or more prolonged hospital course. This is an example of an x-ray of an infant with RSV. And, looking at it, there's nothing that really jumps out at you. There's not a big pneumonia. There's not a huge amount of fluid on the lungs or anything like that. What you do see is just this area here in kind of those initial larger branching airways that just kind of lights up, that kind of peribronchial cuffing or inflammation, we call it. This is not specific for RSV. You can see this in a lot of different viral processes, and it doesn't really give you a clue about how severe their disease is or how they might be impacted or affected by it. The other thing that you can sometimes see on a chest x-ray, especially in a kid that has lower tract disease, is that the lungs are more expanded or more inflated than usual. And that's just showing signs that the air is getting trapped in there and it's a hard time for it to get out again. So X-ray is not usually particularly helpful in diagnosing RSV, but where we might use it is in a kid who's maybe sicker than you expected, has a more prolonged fever, more severe respiratory symptoms. You might be looking for a coexisting bacterial pneumonia or a lung abscess or something along those lines. So for most of us, most clinicians will tell you this is a clinical diagnosis. I'm going to see a patient in the clinic. It's during RSV season. They're presenting with symptoms that are consistent with that. I don't really need to test them. And I spend a lot of time explaining that to families about why that testing really isn't that useful overall, because it doesn't change the course of your management. If the RSV test is positive, I'm not suddenly going to have some other treatment available that's going to help them get better any sooner. I'm not going to automatically put them in the hospital, and I'm not going to give them different guidelines for care than I would for any other respiratory illness. So we don't often do a lot of testing. Sometimes it's useful. Let's say it's the peak RSV season, we're working in the hospital, and we want to try to have patients grouped together to minimize infectious spread within the hospital. Then you might do some testing to say, who do we need to group together? Or in patients where the diagnosis is unclear, where you're like, gosh, I just don't know, is this RSV that now has a secondary pneumonia, or is there some other factor at play where I need that information to guide my clinical management? So it really, especially in the ambulatory setting, we don't do as much testing, or we don't rely on testing to help guide our management. Initially, so way back when this virus was first isolated, the laboratory diagnosis was really not helpful because it took several days to get results back. So by the time you got your test back, the kid already had probably gotten quite a bit better, and it wasn't useful to you anymore. We, of course, now have rapid diagnostic testing and molecular tests, which are the current standard. Those have a rapid turnaround. I can usually get results back in the clinic within an hour or two, and really gives you that kind of fast information. But again, don't necessarily need testing to give you the diagnosis. So our treatment options. This is something I really want to drive home because I think this is frustrating for both healthcare providers and also for families. But there really is no treatment that shortens the course of RSV or hastens the resolution. And my gosh, have we tried to find things that would make a difference for us then. So you've probably in your experience seen different things that have been tried. When you really sit down and look at that, though, none of them do anything to really shorten that course or move things along any faster. And that's, of course, true for a lot of viral illnesses. So really, that supportive care is your only option. And we're talking about things like hydration. We're talking about suctioning mucus from the upper airway to allow easier breathing. Some kids do need supplemental oxygen, and that might be through a nasal cannula. They might need CPAP or even intubation and mechanical ventilation if they're really sick and having trouble oxygenating. There was a treatment, and I remember this from residency, utilizing a medication called aerosolized ribavirin. That's an antiviral medication. It is incredibly expensive. It's very toxic, and there really, over time, was no evidence of clinically relevant benefit. So, again, it's something that we tried that we think would help, but it really just it hasn't proven its worth. Beta agonists like albuterol are also not recommended. And I think this surprises a lot of people because when you think about RSV, automatically your mind goes to wheezing. And when we think wheezing, we think asthma medications and asthma treatment. So the things like albuterol and steroids, even using nebulized epinephrine, these are really not recommended. And again, have been studied and not shown to give benefit in terms of reducing symptom burden or shortening the duration of illness. There is the caveat I will always give with this is that there are a very small percentage of kids who may have underlying asthma or reactive airway disease to whom albuterol does give benefit. So I wouldn't say that we never give albuterol to kids with RSV, but that's a decision that's made clinically while you're evaluating the kid and trying to sort out what the best course forward is for them. So I would say that we do not routinely use nebulizers or inhalers or steroids. Antibiotics are also not indicated, and I think everybody knows that now. We don't use antibiotics to treat viruses, but if there's evidence of a concurrent bacterial infection, if they have otitis media, if they have a pneumonia, bacterial pneumonia, then of course we're going to give antibiotics to treat that bacterial sequelae of their underlying viral illness. So again, not routine for us to utilize antibiotics in that situation. And so here's a little baby that's in the hospital who's getting that supportive care that we talked about. So they've got a IV in the scalp where they're getting some hydration. They've got a feeding tube in the nose, so they're getting some nutrition, and then have a nasal cannula on so that they're getting some supplemental oxygen. We're going to shift and talk just a little bit about prevention strategies because I think this is the exciting part about RSV right now. So everybody, I think, has heard of palivizumab or Synagis, as it's more commonly known, because it's been around forever. This was first approved by the FDA in 1998, and it's a humanized monoclonal antibody. So this is a medication that was considered and developed to reduce the risk of severe RSV disease in high-risk infants. So we're talking about premature infants, kids with congenital heart disease, kids with cystic fibrosis or other pulmonary diseases. It was a monthly injection that you give throughout the RSV season. It's super expensive, a few $1,000s per injection. And it's really the cost versus benefit ratio is not necessarily all that it's cracked up to be, even amongst high-risk infants. And so when I've prescribed palivizumab, I've really cautioned families like, this is not the magic bullet. This is not the thing that's going to keep your child from getting RSV. We still need to use that multi-layered strategy of preventing contact with the virus and doing everything we can to minimize infection as possible. But for the longest time, that was the only tool we had. And so we continued to kind of evaluate who it was appropriate for, and we would go for it. This year is the game changer year. So we have multiple products that were approved by the FDA in the year 2023 and came to market just in the nick of time for our current RSV season. So the first one I'm going to talk about is nirsevimab or Beyfortus. This was approved in July, recommended fairly quickly thereafter by the ACIP and the AAP. It is also a monoclonal antibody against RSV. So you think about it in that similar way that you think about Synagis, but it's better. So thinking back to that slide where we were looking at the proteins on the surface of RSV, the nirsevimab works by binding the F protein. So the virus can't enter into the cell. And it's really good at doing that. It's really good at binding that protein. And it sticks around in the body a lot longer than Synagis does. So the body very quickly breaks down the antibody in Synagis, and that's why we had to do those monthly injections. This one is a one-time dose that you can give to individuals, and it lasts around 150 days, we think. We're going to find out more as we truck through this RSV season, and more research is done on how long that last. But this has been a really exciting development, and it's quite effective. We're looking at the main goal of preventing hospitalization and severe disease, but even I think we're finding it's doing a pretty good job of preventing infection as well. This is not a vaccine, so this is a form of immunity that you give by injection that's effective then immediately. So you're giving those antibodies to the infant, and then the antibodies stay there and do their job. In an immunization, you're giving a substance that triggers the person's own immune system to formulate those antibodies themselves. So that's the difference between nirsevimab and maybe some of the vaccines that are out there. The other options then are Abrysvo and RSV. So these are both vaccines or true immunizations that are approved for use in adults over the age of 60 and also for pregnant women between 32 and 36 weeks gestation. And both of those are approved and pretty widely used. And I think I really appreciate the vaccine strategy on this that was looking at use in that vulnerable elder population as well as our infants. And when we thought about that slide about who RSV tends to affect more severely, we saw that this is a significant disease burden for older adults as well. So the fact that they're able to get some protection, I think, has been pretty exciting. Nirsevimab is well tolerated, really not a lot of issues with side effects, seeing maybe some injection site soreness or redness in that area. With the vaccines, very similar muscle soreness, injection site soreness, might have some headache or kind of mild systemic symptoms. But that's been kind of the majority of side effects that we've heard of. Before we started this RSV season, we had a little bit of a conundrum, which was, do we focus on the maternal vaccine or do we focus on the antibody for babies? Because you can't do both. You have to do one or the other. And there really hasn't been a study that's directly compared them to each other to tell us which one gives better protection. But in the end, the decision kind of got made for us because the supply of Beyfortus from the manufacturer was less than what we needed to immunize all infants. So we were really saying this got to be a dual strategy. Let's vaccinate as many pregnant women as we can, and then we'll use Beyfortus when we have it available and for infants who are eligible. But this has been a really exciting development. One thing that's really interesting is how long these have been in development. So I think we all were kind of shell-shocked when the COVID vaccine was developed and people said, gosh, this happened quickly, or this seems like it was fast, and might have lumped these in the same category. We know, of course, that the technology and the research behind these vaccines has actually been around for a long time. Decades, people have been trying to find a vaccine for RSV. And in fact, there was one that was developed as early as the 1960s. There was a vaccine for RSV, and it was an absolute disaster because when they tested kids, they tested it on kids who were RSV naive, so who had never had RSV infection, and gave it to them. And what happened was the vast majority of kids that got that vaccine in the trial, when they contracted RSV naturally, got super sick with it and ended up hospitalized. So like 80% of the kids who had gotten the vaccine ended up hospitalized. So absolute disaster, did not ever go anywhere after that. And thankfully, what we have available now is a much safer and more effective product. Prevention strategies that you might also see, avoiding exposure to tobacco smoke, very careful hand hygiene. Remember, RSV can live on hands for up to 30 minutes. So really washing your hands before eating, after touching your face, after using the restroom. And then for high-risk infants, or really kind of just young infants in general, avoiding large crowds or group childcare as much as possible. So I liked this little placard, and I've seen a lot of these on like the car seats of NICU graduates or of young infants, to just be a gentle reminder to people to just kind of stay clear. Please don't infect me. I'm vulnerable and have potential for having a more serious complication. And adults, otherwise healthy adults, you might have RSV and not know it. And I've seen plenty of cases where adults have said, well, I just have a mild cold right now, or the kind of famous line, well, it's just my allergies flaring up. Oh, your allergies are flaring up in the middle of winter during RSV season? So it's, I think just reminding people that those viruses can affect infants in a different way. RSV in special populations, I wanted to touch on this just a little bit. So, of course, we think about premature infants as being particularly susceptible, but there's a subset of those infants who have chronic lung disease that can be more deeply affected by RSV. Kids with congenital heart lesions, kids with anatomic pulmonary or neuromuscular disorder. So when you have neuromuscular disorder, you may not have very effective cough or forceful cough and have difficulty clearing your airway. That can set you up for more difficulties with pneumonias and other complications. Immune compromised children, and what we mean by that is kids who have a severe immunocompromise. So they've had a stem cell transplant, they've had a solid organ transplant, and they're on medications to suppress their immune system. Those are kids who are at particular risk of contracting all illnesses. There's evidence that kids with Down syndrome may be more predisposed to RSV disease or more severe disease, and that could have to do with airway differences or difficulty with effective cough. And then children with cystic fibrosis also are at higher risk for developing severe disease. This was exciting stuff for me to learn about, the kind of the stage of current research and development in RSV. One of the things I touched on earlier was that connection between RSV and influenza, and what does it mean for the patient when they have both at the same time, or if you have one and then contract the other, what does that mean for you for the rest of for the respiratory season? Does it mean you're at a higher risk of developing asthma? Does it mean you're at higher risk of hospitalization? A lot of work is being done right now to look at how each of those viruses impacts the immune system individually and then together. A lot of research going on now on the effect on our elder populations, and is that burden of disease higher than maybe we realize? Is this leading to more pneumonias, or how is it impacting their health overall? You'll see the use of wastewater testing in all kinds of seasonal epidemic illnesses now. And the reason that this is key is that because we don't always do a lot of testing, as I mentioned, for RSV. We're diagnosing that clinically, but not confirming for sure that that's what's going on. Looking at wastewater, you can really get a better sense of what's the burden to the community. Are there patients, are we seeing this spike up? And, we have this subset of patients who are not seeking medical care or not getting tested in the medical setting. You can use that then to time your prevention strategy. So that would have been a way that we could have said, oh gosh, we're seeing RSV really on the incline here in August. We're outside of our normal seasonality. We better start giving nirsevimab now rather than waiting until October when we plan, because we're going to miss the peak. So utilizing those wastewater strategies is a good way for RSV, COVID, influenza, really any of those seasonal epidemics. Threat of zoonotic reservoirs. So I said earlier that humans were the only host. That might not actually be true. It sounds like pangolins can be affected with RSV and can contract and spread it to each other. So there is a body of research that looking at, is this an element of this disease that we haven't yet noticed or haven't paid attention to? So thinking about that. Nasal organoids. So I didn't know this was a thing, but you can use stem cells to build a 3D replica of an organ or an organ-like tissue to better study how a virus behaves. So they're actually able to make, I'm going to call it a fake nose, because that's essentially what it is. And then they infect it with RSV, and they're able to study exactly how that virus behaves in its more normal environment. We're going to be looking at vaccination for older infants, toddlers, children, looking at the population as a whole about whether vaccination strategy is a good option. And then we're going to be looking at some different types of vaccines. So there are mRNA vaccines in the pipeline, which may be very effective, and then live attenuated vaccines. That's similar to flu mist, so the nasal spray. That often provides both a cellular and a humoral immune response and gives you a little bit better protection. So those are some things that are in the pipeline. And this is just a table that kind of looks at all the different things in the various phases of clinical trials. So market approved right now, we've got Beyfortus, Synagis, and then those two vaccines we talked about. But in phase 3 trials, we're looking at a monoclonal antibody treatment for high-risk pediatric patients, so something that you could actually give kids who are infected with RSV to help prevent severe disease. And then they're looking at expanding the indication for some of the existing vaccines. And then there's a mRNA vaccine being developed by Moderna for adults over the age of 60. In phase 2 clinical trials, they're looking at that live attenuated vaccine, so the nasal mist for use in toddlers. And then in phase 1 trials, then again, just a variety of different types of vaccines for different specific populations. So I think we're going to see a lot more development and options in the world of RSV prevention and then potentially treatment as well. So more information if you guys are interested. I just as a side note, I have really enjoyed the journal Nature. They'll do a research roundup periodically on some different topics, and I just think it's really interesting and really cool to look at what's coming down the pipeline for any specific thing. So if you're curious about science and you're curious about what's the latest and greatest research, that's how the journal Nature is always a cool place to look for that. If you're looking for more basic information about RSV, the Red Book is great. CDC has a nice subset of information for patients and families, and also for healthcare providers. They link you to a lot of the epidemiologic tracking tools that are out there, so you can kind of get a sense of where we're at in the season and what the disease burden is in any given week. And then the AAP's information for families, healthychildren.org, they really have a lot of nice things too, that is updated frequently. It's very solid information and can be a trusted source of information for families. I like to talk about my why. Why do I want to talk about RSV? And these are two really special ladies in my life, both of whom, at the time this picture was taken, were very susceptible to RSV, and I had a very vested interest in keeping them healthy. So this is my daughter, Amelia, and her great-grandmother, Lois. And just what a special thing that they got to know each other and got to spend time together. But, you know, I think RSV, whether it hits you as just a cold, whether it impacts a loved one or a family member or a patient in a more severe way, it's out there. It's so common. It gets us every year. And it's exciting to think that we've got some strategies maybe that can help us in that battle and help reduce that disease burden. So I'm going to stop sharing right now.
Wonderful. Thank you. That was excellent information. I will turn it over to our storyteller, Siri, and I will share my screen. And there you go.
Awesome. Thanks, Mary.
Siri, there's your why.
That's my why. Yeah, it is. It is. And now I'm looking at this. He's now 16 months old. And I'm like, oh my goodness, it does go fast. Though when we were going through the thick of things, it felt like an eternity. So I want to start by saying that I'm currently now, a nurse here at Sanford, but I had a past life actually in radio. And I bring that up because every year our radio station would hold the Cares for Kids Radiothon. And I just remember interviewing these parents that now I am being about their experiences with their kids having to be hospitalized, having to, go through some pretty extensive treatments for a variety of things. RSV, though, was one of those things. And I just remember every single time they'd say, like, you just never think it's going to happen to you. And that kind of just, I glazed over it, right? Not really thinking about it because it didn't really make a lot of sense to me at that time, other than, oh yeah, I'm sure not. I tell you what, you never think it's going to happen to you. It is so true. So Ivor is my second born. He was born November 18th of 2022. So when Dr. Hanson was talking about the peak of RSV season and what the season looked like in 2022, 2023, that was us. So Ivor was born 7 days late. So he was plenty comfy in there, perfectly healthy pregnancy, perfectly healthy delivery. In fact, he was doing so well, I was doing well, that we were discharged after a day. I was ready to go home. and things were great. In fact, my postpartum with him was even better than the first. So we went home, you know, it was a little before Thanksgiving and then the holiday season. And it does seem like there is more flu illnesses, cold viruses that are going around in the holiday season. However, that wasn't what ended up being the biggest factor in our situation. I have a wonderful firstborn, Oli, who at the time was 2. He was going to daycare. So I was home with Ivor. I was on maternity leave. But about mid-December, Oli brings home yet another cold, which seems like they do every other week. And he came home with, you know, just some sniffles. It was nothing major. You would not think anything of it. You certainly would not think RSV. So he had a few sniffles, and any parent knows of multiple children, you try to keep one child, a toddler, away from a baby, the newborn. Good luck. So we did our best to keep him, you know, back while he was sick. That being said, Ivor at about 4 weeks started to develop some symptoms. So he also started to seem more congested. He was running a little bit of a temp, but nothing too concerning. I should also mention that Oli being born in 2020 at the peak of COVID season was a completely different experience for me as an infant than Ivor in 2022. So these kinds of symptoms with Ivor, I didn't really think much about. I figured he'd clear it, he'd be fine, just like Oli is going to be fine. And it was at about day 5 that we noticed his temperature starting to really spike up into about 100. And being so fresh and new at, you know, only a month old, we were concerned. And I knew enough as a nurse, even though I'm not a pediatric nurse, that maybe we should go in and get him checked out, particularly because he also seemed like he was starting to breathe a little heavier. So we ended up bringing him to the ER with that higher temp, and they brought him back. His O2 was stable. It was staying above about 94%. And they decided to test him, kind of like Dr. Hanson mentioned. It was the peak of a lot of cold flu viruses. So I'm sure they were trying to see what they were dealing with. And so it came back as RSV. And I was kind of like, oh, okay, this is RSV. The ER doctor was wonderful. He said, you know, honestly, only about, you know, 1, 2, 3 out of 100 kids end up needing to be hospitalized. So I'm thinking, great, we'll just go home, supportive care. We'll do what we've been doing, get through this, move on. Within a day, he suddenly spiked up to 105-degree fever. Even though I'm a nurse, I will tell you, like, you still just don't really understand or know exactly, like, do I go back in? Do I not go back in? Am I overreacting? But the 105-degree fever really told me, like, I need to go back in. He was burning up. He felt extremely hot. Those kind of apneic periods where he had these long pauses between breathing, I started to notice. And there is nothing scarier than seeing your child not breathe for what feels like a long time, even though it's a few seconds, but it was super scary. So we ended up rushing back into the ER. They already had tested him and knowing he had RSV, checked his O2, it had started to already decline, and they brought him immediately back. And my husband was meanwhile trying to bring the 3 or 2-year-old to daycare. And so I was back in the ER. We were waiting for a room. That was the time when it was horribly, horribly full in the hospital with RSV and other cases in the pediatrics unit. And so I remember we were in the ER for almost 12 hours just waiting for a room to open up. And by the time we actually were placed, it was already too full on the pediatric floor. So then they overflowed into postpartum unit. Well, it was already full there now. So we were overflowed into the NICU unit. And that's where Ivor, that first picture there on the left, that was him at that time at about a month old. And we were up in the NICU. And I remember calling my husband because he was coming back to the hospital to be with us. And he was like, what's going on? How's he doing? And I said, well, we've been admitted now, and they want to keep an eye on him. They want to hook him up to some oxygen and watch a few things. And I have your classic Midwest stoic husband who shows no emotion. And I can count 3 times him crying. And that was one of those times. And he just lost it on the phone. And it was scary. Again, this was a completely different experience for us than our firstborn and going through his first year of life. Now, thankfully, Ivor was in the hospital for maybe a couple days. It was very brief. He started to turn around really quick. He was eating well. A little bit of oxygen seemed to help him. And we went home. And I remember them again saying like, okay, there's, somewhat of a risk he could have this again. So, watch him, just let us know if you've got questions. But for the most part, you should be in the clear. And we were for the next 5 months. And May comes, Memorial Day weekend. Ivor seemed to be fine all the way up until then. And you think, okay, spring comes, we're good. We're finally out of cold and flu season. And then over Memorial Day weekend, we started to see that same pattern when he got another seeming cold. It immediately started to go to his lungs, the wheezing, the deep breathing, the struggling with the breaths. So I knew we need to go in right away. I went to the urgent care because it didn't seem too emergent at that time. And they checked his O2. Sure enough, he was already down into the 80s. And they said, I don't want to send him home with you, not knowing what his oxygen is going to do, and have him at night be not monitored. And so we were admitted for the second time into the hospital. And that was the time I lost it, because I was like, why is this happening again? Like, this is why us? Why again? He had no seeming risk factors for why he would have RSV or why he would react so poorly to RSV in the first place. But now this second time was what shook me. He was hospitalized for about 4 days. And that was the picture of him on the very right there. He did end up needing high flow oxygen. So he was really having a hard time breathing, clearing secretions. And so that's kind of why he has that different type of nasal device there. And just was really out of it. He did get discharged within about 4 days that time. And again, we go home and we're thinking, okay, this is the end. We finally made it through. We're good. We're going to be careful. And we did everything that we could to be careful with him. But within less than a month, it was the same thing again. Got sniffles, which developed even worse and worse and worse. And this was near the end of June. And we were bringing him to the urgent care, and they were checking his oxygen, again, going down in the 80s. But the funny part is my sweet little boy had the biggest smile on his face, and was just, he did not seem like he was that sick. And so they kept thinking their machine was broken or something was wrong. But they're like, okay, no, given his history and then what this is saying, I think you need to go back into the hospital. And so we go back in, and I tell you what, it was RSV and just bronchiolitis, which is what he was really diagnosed with in the second and third time, is such a strange thing, because we go in and they're looking at him, and he again seems very happy, and all of a sudden his O2 is up into the 90s when we're first admitted, and we feel kind of silly because we're like, did we just get admitted for no reason? But within an hour he went and declined very rapidly. So that's at the end of that hospitalization, that middle picture there. Again, needed to be hooked up to the high flow oxygen. And after all of this, I can thankfully say he has since been pretty stable. We have not been hospitalized again. But as a parent, you're always thinking to yourself, what could I have done better? What did I do wrong? Some of that, like, there's nothing that in a lot of ways you can do. You can do a lot of prevention strategies, but even with that, just realizing just how vicious this virus can be and how unexpected it is, and that you can contract it, your child can contract it without even realizing what they're getting. And now as I look forward to the rest of us growing up, I just think a lot about, I just don't want him to be limited in what he can do. Like, I want him to have the ability to run and play and do sports. And so while we didn't have the opportunity to get the vaccine at the time that he was going through all of this, it is so exciting for me, and especially since I have two younger sisters that are now having kids of their own, to see that they'll have these opportunities to get this vaccine, to be able to prevent these things. Because you just don't want to look back as a parent. You don't want to have to look back and think to yourself, "Ah, I wish I would have done that. Like, it was such a simple thing. If only I would have done that." So very exciting things for me as I look forward to the research that's coming out for vaccines as well. And I just am excited for my own siblings, my nieces, my nephews. And I really hope that the public is also just hopeful and able to be able to utilize the incredible modern technology that we now have available to us.
Wow, what a powerful story. Oh my gosh. And I'm so glad that your little guy is doing so much better. Thank you for sharing that story about Ivor. I know we are at about 3 minutes to 1, and we did have a question come through. And so I do want to just get to that question quick. And there is an evaluation survey that will be emailed out, but there is also a QR code up if anyone would like to take it. We really value those surveys that come in. So maybe you saw the question that came in, Dr. Hanson.
Yeah, I actually see 3 questions here, so I'll just maybe
another
kind of walk through. So one of them says, I haven't seen any published data, but I'd be curious if you could reflect on the past year if there was less severe RSV. I think it's too soon to tell. And, you know, the shortage of nirsevimab, it was tough to navigate. And so, like you said, maybe the impact wasn't as big as it could have been. But I think by later this spring or this summer, we're going to start to see some data come out about what did hospitalizations look like this year? What was the burden on our ambulatory setting? So I think that's a stay tuned. We're going to hear a lot about this in the next 6 to 12 months. The next question is a really good buddy check, which is Arexvy is not approved for maternal patients. Agree 100%. And I neglected to mention that in there. Only Abrysvo is approved for pregnant women and should be used at that 32 to 36 weeks. In especially a family practice setting or a primary care setting, you may have both of them in stock. And I think there's been case reports of people getting the wrong vaccine. We've had infants getting the wrong product. And so really, yes, thank you for that, that reminder. And then in my practice and experience, how accepting were patients of nirsevimab? I was shocked, honestly, at how many people really did want it and really did want it for their infants. And likewise, the maternal vaccine, I felt like had pretty good uptake this year as well. We live in an era of vaccine hesitancy, but we also live in an era where people have a very healthy fear of RSV. And I think many people know someone whose child has been hospitalized or had issues. Main concerns really were those of side effects. And when we were able to really talk through, this is a monoclonal antibody, it's different than a traditional vaccine, I really felt like people were pretty accepting of that. So I thought, you know, when I gave the pitch or when I talked about it, most people opted to go for it, even if they were hesitant about other vaccines. I'll add that as well. Nirsevimab right now is not approved for treatment, and they've been very clear. The FDA and ACIP has been very clear that we're not to be using that way. However, it is not out of the realm of possibility to think that could be a future state. And if you think about the peak of the COVID pandemic, we used monoclonal antibodies as a mainstay of our treatment to help prevent severe disease in susceptible individuals. So whether it's nirsevimab itself or another monoclonal antibody that's in development, I think that's a definite possibility.
All right. And I think all the questions are answered, right? I believe so.
Yeah.
All right. Oh my goodness. This was such a good session. Thank you, Dr. Hanson, for delivering such important information, and Siri for sharing the story of Ivor's story. It was so touching, and I think everyone on this webinar was just educated and really touched by that. To stay connected with us, you can follow Healthy No Doc on Facebook, Instagram, and Twitter. Foundation for Healthy North Dakota on LinkedIn. To join the coalition, you can visit the link to stay aware of future webinars and updates on the foundation. And we really would like to hear stories from community members. We highly value the stories. And so if you know of anyone who has a story to share, or you have one yourself, feel free to get in contact with us directly, or they're in the evaluation survey. There is a section that you could leave a brief description and we can get in touch with you. So thanks again to everyone, and have a great rest of your day.